Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Criselmer Ducanes, clinical instructor teaching critical care nursing. For today's topic, we have the response to altered sensory perceptual function. The human nervous system is a highly specialized system that controls and integrates many activities of the body. In this lecture video, I will be discussing the topic using the 5 phases of the nursing process, namely assessment, nursing diagnosis, planning, implementation, and evaluation. In this way, we will be able to integrate the nursing process in the care of clients with sensory and perceptual problems. First, let's have assessment. Under your assessment, we have your subjective data that includes the important health information of your patient and the functional health patterns. We also have the objective data. It includes the physical examination and diagnostic studies. For the physical examination, the standard neurologic examination helps determine the presence, location, and nature of disease of the nervous system. The examination assesses 6 categories of the nervous system. First, we have your mental status. Second, cranial nerve function. Third, motor function. Fourth, we have your sensory function. Fifth, cerebellar function. And lastly, we have reflexes. Develop a consistent pattern of completing the neurologic examination, as this helps you to remember to include each element every time the examination is performed. For the mental status, assessment of mental status gives a general impression of how the patient is functioning. It involves determination of complex and high-level cerebral functions that are governed by many areas of the cerebral cortex. Much of the mental status examination can be assessed as you interact with the patient. For example, language and memory can be assessed when the patient is asked for details of the illness and significant past events. The patient's cultural and educational background should be taken into account when evaluating mental status. The components of the mental status examination are as follows. First, we have the general appearance and behavior. This component includes level of consciousness, such as awake, asleep, or comatose. It also includes motor activity, body posture, dress and hygiene, facial expression, and speech. Next component is cognition. Note orientation to time, place, person, and situation, as well as memory, general knowledge, insight, judgment, problem solving, and calculation. Common questions are, who were the last 3 presidents? Another question is, what does a person who does not remember where he came from will never reach his destination mean? Or you can also ask the patient to subtract 7 from 100 and keep subtracting 7. Consider whether the patient's plan and goals match the physical and mental capabilities. Note the presence of factors affecting the intellectual capacity, such as retardation, hallucinations, delusions, and dementia. Another component is mood and affect. Note any agitation, anger, depression, or euphoria, and the appropriateness of these states. Direct questions to bring out the feelings of the patient. So these are the components of your mental status. Next, we have the cranial nerves. Testing of each cranial nerve is an essential component of the neurologic examination. All in all, we have 12 cranial nerves, namely olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. Along with this video, I have here the connection with the brain as well as the function of each cranial nerve, either sensory or motor function. Next, we have your motor function. The motor system examination includes assessment of strength, tone, coordination, and symmetry of the major muscle groups. Test muscle strength by asking the patient to push and pull against the resistance of your arm as it opposes flexion and extension of the patient's muscle. Ask the patient to offer resistance at the shoulder, elbow, wrist, hips, knees, and ankles. Mild weakness of the arm is demonstrated by downward drifting of the arm or pronation of the palm. Note any weakness or asymmetry of strength between the same muscle groups of the right and left side. Test muscle tone by passively moving the limbs through the range of motion. There should be a slight resistance to these movements. Next, test cerebellar function by assessing balance and coordination. A good screening test for both balance and muscle strength is to observe the patient's stature, that is, posture while standing, and gait. Note the pace and rhythm of the gait and observe the arm swing. The arm should move symmetrically and in the opposite direction of the leg on the same side. The patient's ability to ambulate is a key factor in determining the amount of nursing care that is needed and the risk of injury from falling. Also, we have to test for coordination and cerebellar function. The finger-to-nose test, having the patient alternately touch the nose, then touch the examiner's finger, and the heel-to-shin test, having the patient stroke the heel of one foot up and down the shin of the opposite leg, test coordination and cerebellar function. Reposition the finger while the patient is touching the nose so that the patient must adjust to a new distance each time your finger is touched. These movements should be performed smoothly and accurately. Other tests include asking the patient to pronate and supinate both hands rapidly and to do a shallow knee bend, first on one leg and then on the other. Dysarthria or slurred speech should be noted because it is a sign of incoordination of the speech muscles. So we have here terms associated to motor function. First is pronator drift. Mild weakness of the arm is demonstrated by downward drifting of the arm or pronation of the palm. Next, we have hypotonia. It is an abnormal tone and it signifies flaccidity. Also, we have your hypertonia. It is also an abnormal tone that signifies spasticity. Also, we have a term called myoclonus. It is the spasm of the muscles. We also have your athetosis. It is the slow, writhing, involuntary movements of extremities. We also have your chorea. It is an involuntary, purposeless, rapid motions. And lastly, we have dystonia. It is an impairment of muscle tone. Now let's proceed to sensory function. Several modalities are tested in the somatic sensory examination. Each modality is carried by a specific ascending pathway in the spinal cord before it reaches the sensory cortex. As a general rule, you should perform the examination with the patient's eyes closed and avoid providing patient with clues. Asking, "How does this feel?" is a lot better than asking, "Is this sharp?" In the routine neurologic examination, Sensory testing of the four extremities is sufficient. In order to test for sensory function, we have to test for touch, pain, and temperature. Light touch is usually tested first. Gently stroke a cotton wisp over each of the four extremities and ask the patient to indicate when the stimulus is felt by saying, touch. Test pain by touching the skin with the sharp end of a pin. This stimulus is alternated with a simple touch stimulus to determine whether the patient can distinguish the two stimuli. The sensation of temperature, on the other hand, can be tested by applying tubes of warm and cold water to the skin and asking the patient to identify the stimuli with the eyes closed. We also need to test for vibration sense. Vibration sense is assessed by applying a vibrating tuning fork to the fingernails and the bony prominences of the hands, legs, and feet. Ask the patient if the vibration or buzz is felt. Then ask the patient to indicate when the vibration ceases. For the position sense, assess position sense by placing the thumb and forefinger on either side of the patient's forefinger or great toe, and gently moving the finger up or down. Ask the patient to indicate the direction in which the digit is moved. And lastly, we have your reflexes. Tendons attached to skeletal muscles have receptors that are sensitive to stretch. A reflex contraction of the skeletal muscle occurs when the tendon is stretched. A simple muscle stretch reflex is initiated by briskly tapping the tendon of a stretched muscle, usually with a reflex hammer. Now let's proceed to the common assessment of abnormalities. First, we have abnormalities from mental status. First is your altered consciousness. The patient is stuporous, mute, and has diminished response to verbal cues or pain. Another one is anosognosia. It is the inability to recognize bodily defect or disease. For speech, we have aphasia or dysphasia, loss or impaired language faculty. So there will be problem in terms of comprehension, expression, or both. We also have your dysarthria. It is the lack of coordination in articulating speech. For the eyes, we have your anisocoria. It is the inequality of pupil size. Also, we have your diplopia, double vision, and homonymous hemianopsia. It is the loss of vision in one side of visual field. For the sensory system, we have your analgesia. It is the loss of pain sensation, and also we have your anesthesia. It is the absence of sensation, and we also have your paresthesia. It is an alteration in sensation. And lastly, we have your asteriognosis. It is the inability to recognize form of object by touch. For reflexes, we have your extensor plantar response or the Babinski sign. It is an upgoing toes with plantar stimulation. And we have your deep tendon reflexes, diminished or absent motor response. For the spinal cord, we have bladder dysfunction, under which we have your atonic. It is the absence of muscle tone and contractility, enlargement of capacity, no sensation of discomfort, overflow with large residual, and inability to voluntarily empty. We also have your hypotonic, more ability than atonic bladder but less than normal. For the hypertonic, it is increased in muscle tone, diminished capacity, reflex emptying, dribbling, and incontinence. We also have your paraplegia. It is the paralysis of lower extremities. And your tetraplegia or quadriplegia. It is the paralysis of all extremities. For the cranial nerves, we have your dysphagia. It is the difficulty of swallowing. And your ophthalmoplegia. It is the paralysis of eye muscles and papil edema, choke disc or swelling of optic nerve head. For the motor system, we have your apraxia. It is the inability to perform learned movement despite having desire and physical ability to perform them. We also have your ataxia. It is lack of coordination of movement. Next is dyskinesia. It is an impairment of voluntary movement resulting in fragmentary or incomplete movements. We also have your hemiplegia. It is the paralysis on one side. And nystagmus. It is the jerking or bobbing of eyes as they track moving object. So now let's proceed to the Glasgow Coma Scale, also known as GCS, and your National Institute of Health Stroke Scale, or NIH Stroke Scale. The Glasgow Coma Scale, or GCS, is a quick, practical, and standardized system for assessing the degree of impaired consciousness. The three areas assessed in the GCS correspond to the definition of coma as the inability of a patient to speak, obey command, or open the eyes when a verbal or painful stimulus is applied. Specific assessments evaluate the patient's response to varying degree of stimuli. Three indicators of response are evaluated. First, the opening of the eyes. Second, the best verbal response. And third, the best motor response. Specific behaviors observed as responses to the testing stimulus in each of these three areas are given a numeric value and can be plotted on a graph. Your responsibility is to elicit the best response on each of the scales. The higher the scores, the higher the level of brain functioning. Use a graph to determine whether the patient is stable, improving, or deteriorating. The subscale scores are particularly important if a patient is untestable in one area. For example, severe periorbital edema may make eye opening impossible. The total GCS score is the sum of the numeric values assigned to each of the three areas evaluated. The highest GCS score is 15 for a fully alert person, and the lowest possible score is 3. A GCS score of less than or equal to 8 is generally indicative of coma. So we have here the interpretation for your GCS. For the best response, we have 15. Comatose client, we have 8 or less. And totally unresponsive, we have a score of 3. The GCS offers several advantages in the assessment of the unconscious patient. It allows different healthcare professionals to arrive at the same conclusion regarding the patient's status and can be used to discriminate between different or changing states. In case of stroke or hemorrhage associated with decreased ICP, the NIH or the National Institutes of Health Stroke Scale should be used. Other components of the neurologic assessment include cranial nerve assessment and motor and sensory testing. In addition, the National Institutes of Health Stroke Scale is a tool used by healthcare providers to objectively quantify and succinctly communicate the impairment caused by a stroke. We also have another tool here known as your full outline of unresponsiveness or force score. So in this tool, we have 4 indicators. We have your eye response, motor response, brainstem reflexes, and respiration. So the interpretation for this, we have your minimum score as 0 and maximum score is 16. The interpretation for this tool is that the lower the score, the greater the coma. Now let's proceed to your diagnostic studies. First, we have your cerebrospinal fluid or CSF analysis. Under that, we have your lumbar puncture. For the radiology, we have your skull and spine X-ray, cerebral angiography, and computed tomography or CT scan. In addition to radiology, we also have your magnetic resonance imaging or MRI and magnetic resonance angiography or MRA. Also, we have your positron emission tomography or your PET scan and single photon emission computed tomography or your SPECT. And lastly, we have your myelogram. For the electrographic study, we have your electroencephalography or your EEG. Also, we have here your electromyography or the EMG and nerve conduction studies. For the ultrasound, we have your carotid duplex studies and transcranial Doppler. Now let's proceed to the neurologic alterations. So we have here increased intracranial pressure. We also have traumatic brain injury, acute ischemic stroke. We also have your seizure disorders and epilepsy. And lastly, we have your traumatic spinal cord injury. First, let's have your intracranial pressure. Intracranial pressure, it is the hydrostatic force measured in the brain CSF compartment. Under normal conditions in which intracranial volume remains relatively constant, the balance among the three components, the brain tissue, the blood, and CSF, maintains the ICP. Factors that influence ICP under normal circumstances are changes in, first, arterial pressure, second, venous pressure, third, intra-abdominal and intrathoracic pressure, fourth, posture, fifth, temperature, and lastly, blood gases, particularly carbon dioxide levels. The degree to which these factors increase or decrease the ICP depends on the ability of the brain to accommodate to the changes. ICP can be measured using a pressure transducer. Normal intracranial ICP ranges from 5 to 15 millimeters of mercury. A sustained pressure above the upper limit is considered abnormal. Now let's discuss the Monro-Kelly doctrine. It is a compensatory mechanism of the brain to maintain the normal intracranial pressure. The modified Monro-Kelly doctrine states that the three components must remain at a relatively constant volume within the closed skull structure. If the volume of any of the three components increases within the cranial vault and the volume from another component is displaced, the total intracranial volume will not change. This hypothesis is only applicable in situations in which the skull is closed. The hypothesis is not valid in neonates and in adults with displaced skull fractures. Next, let's have cerebral blood flow or CBF. It is the amount of blood in milliliters passing through 100 grams of brain tissue in 1 minute. The global CBF is approximately 50 ml per minute per 100 grams of brain tissue. The maintenance of blood flow to the brain is critical because the brain requires a constant supply of oxygen and glucose. The brain uses 20% of the body's oxygen and 25% of its glucose. The brain has the ability to regulate its own blood flow in response to its metabolic needs despite wide fluctuation in systemic arterial pressure. Autoregulation is the automatic adjustment in the diameter of the cerebral blood vessel by the brain to maintain a constant blood flow during changes in arterial blood pressure. The purpose of autoregulation is to ensure a consistent CBF to provide for the metabolic needs of brain tissue and to maintain cerebral perfusion pressure within normal limits. Now let's have cerebral perfusion pressure or CPP. It is the pressure needed to ensure blood flow to the brain. CPP is equal to the mean arterial pressure minus the intracranial pressure. This formula is clinically useful, although it does not consider the effect of cerebral vascular resistance. As the CPP decreases, autoregulation fails and CBF decreases. The normal CPP is 16 to 100 millimeters of mercury. A CPP less than 50 millimeters of mercury is associated with ischemia and neuronal death. A CPP less than 30 millimeters of mercury results in ischemia and is incompatible with life. Normally, autoregulation maintains an adequate CBF and perfusion pressure primarily by adjusting the diameter of the cerebral blood vessels and metabolic factors that affect ICP. It is critical to maintain the MAP when ICP is elevated. It is important to remember that CPP may not reflect perfusion pressure in all parts of the brain. There may be local areas of swelling and compression limiting regional perfusion pressure. Thus, a higher CPP may be needed for these patients to prevent localized tissue damage. For example, a patient with an acute stroke may require higher BP, increasing MAP and CPP in order to increase perfusion to the brain and prevent further tissue damage. Now let's have increased intracranial pressure. Any patient who becomes acutely unconscious, regardless of the cause, should be suspected of having increased ICP. Increased ICP is a potentially life-threatening situation that results from an increase in any or all of the three components, your brain tissue, blood, and CSF, within the skull. Elevated ICP is clinically significant because it diminishes CPP, increases risk of brain ischemia and infarction, and is associated with a poor prognosis. Increased ICP can be caused by a mass lesion, example, hematoma, contusion, abscess, or tumor. Cerebral edema associated with brain tumors, hydrocephalus, head injury, or brain inflammation, or metabolic insults. Now let's have the nursing diagnosis. First, we have here decreased intracranial adaptive capacity related to decreased cerebral perfusion or sustained increased ICP. Next, we have risk for ineffective cerebral tissue perfusion related to reduction of venous and or arterial blood flow and cerebral edema. We also have risk for disuse syndrome related to altered level of consciousness, immobility, and altered nutritional intake. For the planning, we have here the overall goals are that the patient with increased ICP will maintain a patent airway, have ICP within normal limits, demonstrate normal fluid and electrolyte balance, and have no complications secondary to immobility and decreased level of consciousness. For the collaborative therapy, so we have to elevate the head of the bed 30 degrees with head in a neutral position. This is to promote drainage of your CSF, thus decreasing the pressure inside your brain. Also, we need intubation and mechanical ventilation if oxygenation is compromised. We also have to monitor the ICP of the patient. Cerebral oxygenation monitoring as well, and maintenance of partial pressure of oxygen equal or greater than 100 millimeters of mercury, and maintenance of fluid balance and assessment of osmolality or concentration. and maintenance of systolic arterial pressure between 100 and 160 millimeters of mercury. And also, we have to maintain the CPP of our patient to more than 60 millimeters of mercury to promote cerebral perfusion and reduction of cerebral metabolism. The ICP can be monitored through ventriculostomy, intraparenchymal fiber optic catheter, epidural transducer, subdural catheter, and subdural bolt. So these catheters will be connected to a monitor that will read the pressure inside the brain. For the drug therapy of increased ICP, we have here osmotic diuretic in the form of mannitol. This medication can pass through the blood-brain barrier, and in effect, it can drain excess CSF or fluid from the brain in order to decrease the intracranial pressure. We also have your anti-seizure drug or your phenytoin in case that seizure is manifested. We also have corticosteroid in the form of your dexamethasone, that is to decrease the inflammation of your brain tissue, thus decreasing the intracranial pressure. And also we have your histamine, H2 receptor antagonist or photon pump inhibitor. This is to prevent GI ulcers and bleeding caused by the administration of your corticosteroids. So here is the ventriculostomy. So there is an opening made in the skull of your patient in order to drain excess CSF from the ventricles, thus decreasing the amount of CSF in the brain, and thereby it would decrease intracranial pressure. For the nursing implementation, we have first is to secure the respiratory function. We also have fluid and electrolyte balance, monitor intracranial pressure, and protection from injury in case of seizure. Next, we have your head injury. It is a broad classification that includes any injury or trauma to the scalp, skull, or brain. A serious form of head injury is traumatic brain injury. So we have here different types of your head injuries. First, we have your scalp lacerations, skull fractures, and head trauma. For the scalp lacerations, these are an easily recognized type of external head trauma. Because the scalp contains many blood vessels with poor constrictive abilities, most scalp lacerations are associated with profuse bleeding. Even relatively small wound can bleed significantly. The major complications associated with scalp laceration are blood loss and infection. We also have your skull fractures. Skull fractures frequently occur with head trauma. Fractures may be closed or open depending on the presence of a scalp laceration or extension of the fracture into the air sinuses or dura. The type and severity of a skull fracture depend on the velocity and momentum, the direction and shape, either blunt or sharp, of the injuring agent and the site of impact. Lastly, we have your head trauma. Brain injuries are categorized as diffuse or generalized injury. It is the damage to the brain that cannot be localized to one particular area of the brain. Examples are concussion and diffuse axonal injury. Another category of head trauma is your focal localized injury. It can be localized to a specific area of the brain. Examples are contusion and hematoma. So we have here associated terms with regards to your head trauma. First is your concussion. It is a sudden, transient mechanical head injury with disruption of neural activity and a change in the level of consciousness. We also have your diffuse axonal injury. It is a widespread axonal damage occurring after a mild, moderate, or severe traumatic brain injury. We also have your contusion. It is the bruising of the brain tissue within a focal area, and it is associated with closed head injury. And lastly, we have hematoma. It is a collection of blood outside of a blood vessel. So here is an example of your concussion. A concussion is a violent jarring or shaking that results in disturbance of the brain function. We also have here an image showing brain contusion. For the concept of diffuse axonal injury, we have here the nerves that are stretched or pulled. Also, we have here the nerve that is teared, and there is complete shearing of the nerve. Now let's proceed to the classification of your brain injury. So it is classified as minor brain injury if the patient has a GCS of 13 to 15. For moderate brain injury, we have GCS 9 to 12, and for severe brain injury, we have GCS 3 to 8. So these are the three classifications of your brain injury. Now let's have the nursing diagnosis. So first, we have the risk for ineffective cerebral tissue perfusion, hyperthermia, acute pain or headache, impaired physical mobility, anxiety, and potential complication of increased ICP. For the planning, so we have to maintain adequate cerebral oxygen perfusion, remain normothermic, or the temperature of our patient should be in the normal range, achieve control of pain and discomfort, free from infection, and attain maximal cognitive, motor, and sensory function. For the emergency management, first we have the initial management, so we have to ensure patent airway, stabilize cervical spine. We also have to administer oxygen via non-rebreather mask. Also, we have to establish IV access with 2 large bore catheters to infuse normal saline solution or lactated Ringer's solution. Also, we have to control external bleeding with sterile pressure dressing and assess for rhinorrhea, otorrhea, or scalp wounds. For the ongoing management, we have the maintenance of patient's warmth using blanket, warm intravenous fluids, overhead warming lights, warm humidified oxygen. Also, we have to monitor vital signs, level of consciousness, oxygen saturation, cardiac rhythm, GCS, pupil size, and reactivity. Also, we have to anticipate need for intubation if gag reflex is impaired or absent, and assume neck injury with head injury. And also, we have to administer fluids cautiously to prevent fluid overload and increasing intracranial pressure. For the nursing implementation, we have health promotion. One of the best ways to prevent head injuries is to prevent car and motorcycle collisions. The use of helmets by cyclists has led to fewer traumatic brain injuries. The use of car seat belts and the use of child car seats are also associated with reduced traumatic brain injury mortality rates. We also have acute intervention. Management at the injury scene can have a significant impact on the outcome of the head injury. The general goal of nursing management of the head injured patient is to maintain cerebral oxygenation and perfusion and prevent secondary cerebral ischemia. Lastly, we have ambulatory and home care. Once the condition has stabilized, the patient is usually transferred for acute rehabilitation management to prepare the patient for re-entry into the community.